And this is our third patient on our respiratory virtual ward round. So this is a patient who's been admitted today straight to the ward side room, and essentially he's a 34-year-old male, originally from India, who's been in the UK for 4 years. Presents with 20 days of fever, night sweats, shortness of breath, a few streaks of hemoptysis, and half stone weight loss. In terms of observations, fairly normal set, apart from slightly higher respiratory rate at 24 per minute. And at examination, he's got some right-sided chest crackles. So he has a chest x-ray which shows quite considerable right upper zone changes. So he's got shadowing, in fact, throughout the right upper and right mid zones, quite dense shadowing. There is a bit of apical sparing, if you can see, just above the right clavicle, but otherwise, a reasonable example of what is probably underlying consolidation. Given the presentation, we're really thinking about things like TB in the differential here, but actually it may not be TB. So it's just worth thinking about other differentials because, although this patient has got a lot of features in the history which would be suggestive of TB, it might be something else. It might be a case of community-acquired pneumonia. It could be, unfortunately, a case of lung cancer. And again, it's very difficult to tell just from the basis of the chest x-ray. So thinking about initial management, initial investigations, it would certainly be appropriate to admit this patient to a side room in case it is pulmonary TB, because obviously that's a high risk of infection for other patients, other staff, etc. Thinking about screening for TB, we want to get 3 sputum samples for culture, but also for alkyl acid fast bacilli. Blood testing would be done, including an HIV test and vitamin D levels. It's well recognized that vitamin D deficiency can essentially hinder the immune response to fighting infection, including TB. So therefore, if there's any suggestion of vitamin D deficiency, we want to also replace vitamin D levels. Given the wide differential, I think a CT scan would be entirely appropriate. And I think at the moment, we don't really know yet whether or not this is TB or pneumonia. So whilst we're waiting for the results of these investigations to come back, particularly the acid-fast bacilli results of the sputum, it may be appropriate to start this patient on broad-spectrum antibiotics as per pneumonia guidelines, which, whatever they are locally, as per local pneumonia care bundles, until getting some more evidence back to confirm that the patient definitely has got TB. And some of you may be reasonably thinking about why don't we just start TB treatment straight away? Well, the reason for that is that actually sometimes these cases do turn out to not be TB. Like I said, there are other differentials, and we know that anti-TB therapy, it can be potentially quite toxic. So therefore, it's important that we are certain about the diagnosis before we embark on a long duration of antibiotics for TB. Having said that, if you have a patient who's critically unwell, for example, somebody who is admitted, if it was a different patient, similar presentation, but much more unwell, and for example, hemodynamically unstable, or even in respiratory failure, or at risk of fairly immediate death unless you intervened, then in that case, you'd probably think about starting the TB treatment before you get results of your TB diagnosis back. But it's not that often that patients with TB present like that. And clearly, if the patient is not producing a sputum, then we need to get some sampling, and the next really sort of best way of doing that would be a bronchoscopy with some sort of lavage or washout of the affected part of the lung, and then those sort of secretions can then be sent for investigation for underlying AIFB on microscopy. So the next day we do get the patient's sputum microscopy back, and this is a good example of Zeal-Nielsen staining. We can see in purple the alcohol acid-fast bacilli. So now we've sort of confirmed TB, which was our strong suspicion before. What is the treatment now? What kind of baseline test should we be thinking about doing? And what kind of counselling should we be thinking about, particularly in relation to the sort of side effects of medications we're going to embark on? Well, it's important, obviously, to get public health informed and to initiate contact tracing. Most hospitals will have their own team of TB specialist nurses who can lead on this kind of aspect. And again, because we know that evolving multi-drug resistant TB is becoming a problem worldwide, we use multiple antibiotics. Therefore, we aim for giving quadruple therapy in the first instance. That means 4 different antibiotics together. So for pulmonary TB, it's generally 6 months of treatment in total. So the first 2 months are the quadruple therapy, which is rifampicin, isoniazid, pyrazinamide, and ethambutol. You might remember the RIPE mnemonic to remember these together. And then after 2 months, we drop 2 of the medications and just continue in the continuation phase for another 4 months of rifampicin and isoniazid. The isoniazid itself can actually result in a vitamin deficiency, which is vitamin B6, and the consequence of that can be peripheral neuropathy. So therefore, to avoid that, we automatically put patients who are on isoniazid also on pyridoxine, which essentially is vitamin B6, to try and reduce that risk of developing peripheral neuropathy. And then it's essentially a waiting game, waiting for culture results to come back. So although we've had the initial microscopy confirming acid-fast bacilli, we need the culture of the sputum to come back, and that can take several weeks. And that will look at the sensitivities of which antibiotics are actually particularly helpful for this organism, this patient's growing. Having said that, more frequently now, we're using something called GeneXpert, which essentially is PCR analysis, which is more expensive, but it is becoming more readily available, and the advantage is it gives you a much quicker answer in terms of what are the drug sensitivities for your organism. So if you suspect, for example, you've got a patient who may have multi-drug resistant TB, then clearly GeneXpert is going to be very useful. Or if you notice that patients not responding within the first few days to their TB therapy, then certainly that may also be an indication to sort of get a GeneXpert test done and not have to wait that 6, 7, 8 weeks for your full sputum culture results to come back, by which time the patient may have significantly deteriorated if they have a genuine multi-drug resistant TB. So in terms of side effects, there are a lot, unfortunately, but again, this is why I think it's worth counselling patients about these common side effects before you embark on this quadruple therapy. So for rifampicin, essentially the main concern is hepatitis, and it can be life-threatening hepatitis if we're not careful or not monitoring things properly. The usual other side effects include rashes, febrile reaction. Interestingly, it causes orange-red secretions, including contact lenses. So it's really important to tell patients about this before they start urinating red, when they start seeing red if they've got contact lenses and think, what is going on? And also there's many other drug reactions with anything essentially which is metabolized through the liver. So we have to be very careful about other drugs which are commonly metabolized via the liver mechanism. Isoniazid, again, can cause significant hepatitis, rashes, peripheral neuropathy, which we talked about already, and also some cases psychosis. So again, you have to be very careful if that happens. For example, patients, if that results, then they may want to, for example, leave hospital if they haven't got mental capacity. So that can be quite challenging if you have to deal with that situation. Pyrazinamide again can cause similar side effects, but the main unique one to that is arthralgia. So patients can get really quite bad joint pains as a result of pyrazinamide. And ethambutol, the clear concern is relating to vision and loss of vision altogether. So really, in relation to those side effects, it's really important before embarking on these treatments that we must have some baseline liver function tests, as well as visual acuity testing, and clearly some ongoing assessment of these as treatment continues, with appropriate advice given to patients. For example, if any sudden change of vision, then they should stop taking the treatments and seek urgent medical advice and review. So TB treatment adherence can be a challenge, and there are certainly some groups of people who are more at risk of having lower adherence, including, for example, homeless people, people who use alcohol or substance abusers, and also patients who may have underlying mental health issues or lack capacity for whatever reason. And these patients might benefit from having a sort of more supervised regime, something we call directly observed therapy, which essentially involves attendance 3 times a week to have supervision of medications given by usually a specialist nurse, but it could be a trained pharmacist or any member of the team who's interested and involved in that side of care. And clearly, because that's a sort of 3 times a week rather than a daily regime, that the doses of the medication are slightly different in that DOT therapy regime. In addition, again, if patients are wandering off, for example, if somebody's admitted with pulmonary TB and thought to still be infectious risk to others, but they're not complying and they're not staying in the side room, or they're threatening to, for example, self-discharge, then under the Public Health Act, it is possible to get some help from law enforcement, police, to actually restrain people and bring them back to have treatment. In this, I think this is probably the only indication for physical, illnesses where we can really sort of try and use that legal help or legal framework. So this very useful picture taken from Nature Reviews really just reminds us what happens. It's essentially when you inhale Mycobacterium TB through the respiratory tract, essentially the organism enters your lungs and you develop this thing called a primary gone focus, and it's sort of this primary lesion becomes sort of made up of a variety of cells, including T cells, these giant cells, and infected macrophages. And this is a microscopic thing called primary gone focus, which essentially may remain dormant for many, many years. And then essentially at some point it may reactivate to become active TB. So latent TB is another important thing to think about. So this is essentially the concept of somebody who's been exposed to a patient who has had pulmonary TB. So therefore, this person has been exposed to the other patient with pulmonary TB. He's at risk of also developing pulmonary TB at some point in the future. So that's what we call latent TB, and that's really confirmed by that contact with another person, but also there are some objective tests that we can do, including a MAN2 skin test and a blood test called interferon gamma blood test, otherwise known as quantiferon. So essentially, if patient, for example, it could be a relative of the case that we've admitted who has got TB, essentially, despite the fact that they are asymptomatic and they have a normal chest X-ray, but if they have had close contact with a positive TB case and they've got this positive blood test, interferon gamma blood test, then essentially they are somebody who is at real risk of developing full active TB in the future. And therefore we would offer these kind of close contacts prophylactic treatment, and that's usually a combination of rifampicin and isoniazid for between 3 and 6 months with really close follow-up, including X-ray follow-up at regular intervals. There are nice TB guidelines which will give you more information on latent TB, but also TB in general if you want to have a look at those. So just to finish off this case, this is just really to show you in terms of where we're at in Leicester compared to the rest of the UK. It's a slightly older data from mid-2000s, but it does demonstrate a good point that clearly due to the ethnic minority makeup of Leicester, we do have a higher incidence of TB compared to the rest of the United Kingdom. But really, since my colleagues have set up a latent TB program where they've tried to, pick up cases and offer them prophylactic treatment before they develop pulmonary TB, I think that has been something which has been successful in terms of halting the rise of incidence significantly of TB locally.